Welcome to the deep dive. Today we're getting into a really key topic, especially for revision. Aortic valve stenosis, or AVS, definitely one you need to know well.
Absolutely. Yeah, think of this as your high-yield AVS revision session. We're aiming to, pull out the core info from the notes and make it really clear.
Make it stick.
Exactly. Break it down, hit the important bits so you feel confident.
And we've got some memory aids, some mnemonics lined up to help with that too. We've gone through the revision notes on aortic valve stenosis, so let's dive in. Okay, first up, definition. What is aortic valve stenosis in simple terms?
Right. So aortic valve stenosis, at its core, it's a narrowing of the aortic valve.
Okay.
Now, this valve, it's the doorway between the left ventricle, the heart's main pumping chamber, and the aorta, which is the big artery taking blood to the body.
Got it.
When that doorway gets narrow, it obstructs the blood flow out. It makes it harder to push blood through.
So the heart has to work harder.
Precisely. The left ventricle has to generate much higher pressure to squeeze the blood out, and this reduces the overall blood flow getting to the rest of the body.
Like trying to push something thick through a narrow pipe? Okay. What about the normal valve? What should it look like?
A healthy one has 3 thin leaflets, or cusps. They open up wide when the heart pumps and then snap shut tightly afterwards to stop blood flowing backwards. It ensures that one-way traffic from the ventricle to the aorta right at the aorta's start.
3 leaflets, one-way flow. Got it.
Now, I've seen the term aortic sclerosis mentioned alongside stenosis. How do they relate?
Good point. Aortic sclerosis is kind of like, well, it's often a precursor. Sclerosis means the valve leaflets are getting thicker, stiffer, maybe some calcium buildup.
Okay.
It's actually really common, especially as people get older, but it doesn't necessarily mean there's a significant blockage yet.
So it's like an early stage. You could think of it that way. If that stiffening and calcification gets bad enough that it actually restricts the opening, then we call it stenosis. So yeah, sclerosis can lead to stenosis, the degenerative kind.
Okay, that makes sense.
Yeah.
So sclerosis is the thickening, stenosis is the actual narrowing. What causes this stenosis then? What are the main etiologies?
We generally split them into 2 buckets, congenital and acquired.
Born with it or develops later?
Exactly. Congenital AVS means the valve just didn't form quite right before birth.
A structural problem from day one.
Right. Then you've got acquired AVS. And the big one here, especially in older adults, is age-related calcification. Degenerative AVS.
Just wear and tear over time.
Pretty much. Years of opening and closing, calcium deposits build up, and the valve narrows. It's the most common cause overall.
Are there other acquired causes we need to flag?
Yes, definitely. Rheumatic fever is another important one.
Right, from strep throat complications.
Exactly. It's an inflammatory response that can damage heart valves years later, including the aortic valve, leading to scarring and stenosis. Okay. Less common causes, but still relevant, include having a bicuspid aortic valve.
Born with 2 leaflets instead of 3.
Yes, and that can wear out quicker. Also, a history of infective endocarditis, that's an infection on the valve, or even radiation therapy to the chest area can sometimes cause it.
Okay, so congenital issues, wear and tear, inflammation, or other damage.
Yeah.
Got it. Now, who's more likely to develop AVS? What are the key risk factors?
Well, for the congenital type, a family history of congenital heart defects is a factor. Also, certain genetic conditions like Turner syndrome.
Okay.
For the acquired forms, as we said, a history of rheumatic fever is a big one.
And age, obviously, for the calcific type.
Absolutely. Advanced age is a major risk factor for degenerative AVS. Also, having had infective endocarditis before.
Right.
And that previous radiation therapy to the chest we mentioned.
Okay, clear list of risk factors.
Right.
So we know what it is, who gets it. Let's dig into the mechanics, the pathophysiology. What's actually happening inside the heart with AVS?
Right. This is key to understanding the symptoms. So, the narrowed valve, it acts like a bottleneck. It restricts blood leaving the left ventricle. So to push blood through that smaller opening, the left ventricle has to pump much, much harder.
Generates more pressure.
Exactly. And just like any muscle that works harder, it gets thicker. We call this left ventricular hypertrophy, or LVH.
Like lifting weights makes your biceps bigger.
Precisely. Initially, this thickening helps the heart compensate, helps maintain blood output, but
there's always a but.
There is. Over time, that thickened muscle can become stiff. It doesn't relax properly to fill with blood, and eventually it just can't keep up.
So the compensation fails.
Right. The reduced blood flow finally getting out to the body starts causing symptoms, and the heart's overall function gets compromised. It can lead towards heart failure if that obstruction isn't relieved.
That really explains the progression. Okay, so if someone comes in with symptoms that sound like AVS, what else should be on the differential diagnosis list? What else could it be?
Yeah, super important. You need to think about other things that might cause similar issues, especially other causes of left ventricular outflow obstruction.
Why?
Things like subvalvular aortic stenosis, narrowing below the valve, or supravalvular narrowing above it.
Okay.
Then there's hypertrophic cardiomyopathy, where the heart muscle itself is too thick and obstructs outflow, and coarctation of the aorta, which is narrowing further down the aorta.
Different kinds of blockages in the same pathway, essentially.
Exactly. And then you also have to think about things that cause similar heart murmurs, because the murmur is often the first clue.
Right. What else causes murmurs like that?
Well, aortic sclerosis itself can cause a murmur, even without severe stenosis. Aortic regurgitation, a leaky aortic valve.
Uh-huh.
Infective endocarditis can cause murmurs, a dilated aortic root, and don't forget flow murmurs. These are often innocent sounds caused by increased blood flow, like in anemia or an overactive thyroid, or even with aortic regurgitation itself. And occasionally you might need to differentiate from murmurs arising from the right side, like pulmonary valve issues, although the location is usually different.
So lots to consider. Need the full clinical picture. Now, how common is AVS? What's the epidemiology look like?
It's a bit tricky to get exact UK numbers easily, but the key points are: AVS is actually one of the most common congenital heart defects found in newborns.
Really? Okay.
Yeah, and then, as we've said, acquired AVS is very common in older adults thanks to that degenerative calcific process, so it spans the age range for different reasons.
So definitely not a rare condition. How does it usually present then? What clinical features should we look out for?
It really varies depending on severity. Mild cases, people might have zero symptoms for ages, completely asymptomatic.
Right.
But as the stenosis gets worse, the classic triad of symptoms starts to appear. Chest pain, which is like angina, shortness of breath, especially with activity, and feeling dizzy or even fainting, syncope. Fatigue is also common, and sometimes palpitations.
And what about in babies or young kids with congenital AVS?
Yeah, the signs can be different there. You might see poor feeding, difficulty gaining weight, what we call failure to thrive, and maybe developmental delays if it's significant.
Okay. Are there any really classic signs, maybe some memory tricks for the key symptoms?
Yes, mnemonics can definitely help lock these in. For that shortness of breath on exertion, you could think, out of breath doing exercise.
Okay, exercise.
For the angina-like chest pain, angry chest pain.
Angry chest pain. Nice.
And for the dizziness or fainting, feeling dizzy might sink.
Dizzy sink. Got it.
Other key signs on examination include a slow rising pulse. It feels gradual and weak, often with a narrow pulse pressure. Think of a weak, gradual push.
Okay.
And listening to the heart, the classic finding is a harsh systolic ejection murmur. Remember, harsh sound during forceful ejection.
Harsh ejection sound makes sense.
You might also hear an ejection click, especially in kids with congenital AVS. It's an extra sound early in systole. Think early click. And in severe cases, you might find signs of that left ventricular hypertrophy we talked about.
Those are really helpful. Okay, so if AVS is suspected, based on these features, what investigations are needed to confirm it and see how bad it is?
Right, diagnosis time. An ECG is usually done first. It might show signs of that left ventricular hypertrophy or strain.
Okay.
A chest x-ray could show if the heart's enlarged or maybe calcification on the valve, but honestly, it can often look pretty normal early on.
So the echo is the big one.
Absolutely. Echocardiography is the key investigation. It uses ultrasound to give us detailed pictures of the heart.
What can it show us?
It lets us see the valve itself, how thick it is, how much calcium, how well it's opening. We can assess the severity of the narrowing. We look at the left ventricle's function, wall thickness, check for other valve issues. It's crucial for diagnosis and also gives prognostic information. We usually do a transthoracic echo through the chest wall. Sometimes a transesophageal echo down the throat gives clearer views. And Doppler echo measures blood flow speed across the valve. Faster speed means tighter stenosis.
Makes sense. What about exercise testing? Is that ever used?
It's generally not done if the patient already has symptoms. It can be risky,
Okay.
but it can be useful in asymptomatic patients who have severe AVS, especially if they're active. It can help unmask symptoms that only come on with exertion, and it helps with risk stratification. But it absolutely must be done under supervision.
Safety first. Any other imaging?
Yeah, sometimes MSCT, multi-slice CT, or cardiac MRI might be used. They can give more detail, especially about the aorta if it looks enlarged. MSCT is also good for quantifying the valve area, checking coronary artery calcium, and it's really important for planning TAVI procedures.
TAVI planning, right.
Also, blood tests for natriuretic peptides, like BNP, can be useful. They can help predict outcomes in asymptomatic patients with severe AVS.
Okay. And more invasive tests, like cardiac cath.
Cardiac catheterization is sometimes needed. It involves putting a catheter into the heart to directly measure the pressure gradient, the pressure difference across the valve. It gives a very accurate severity measure.
The gold standard for pressure measurement.
You could say that. And often, coronary angiography is done at the same time, especially in older patients, to look for any coronary artery disease because the risk factors overlap quite a bit.
Right. Check the pipes at the same time. Makes sense? Okay, comprehensive workup. So once diagnosed, how is AVS managed, say, in the UK?
Management really hinges on the severity and whether there are symptoms. Medically, it's important to know that statins aren't specifically recommended just to slow down the AVS progression itself,
Oh.
but managing other atherosclerotic risk factors like cholesterol and blood pressure is crucial. For patients who aren't candidates for intervention, medications are used to manage symptoms like heart failure or coexisting hypertension.
And when does intervention come into play?
Well, for patients with severe AVS and symptoms, the recommendation is generally for early intervention. That usually means either surgical aortic valve replacement, SAVR, or TAVI.
Surgery or the catheter-based?
Right. For severe high-gradient AVS, intervention is usually advised even if the left ventricle function, the LVEF, looks okay. It's a bit more nuanced if the gradient is low and the LVEF is reduced, needs careful assessment.
What if someone has severe AVS but no symptoms?
Good question. If they have severe AVS and their LV function is already impaired, intervention is usually recommended even without symptoms.
Right.
If they have severe AVS, no symptoms, and good LV function without other worrying features, then often it's watchful waiting, regular monitoring.
Keep a close eye on them.
Exactly. Although some asymptomatic patients might still be considered for intervention if they have certain high-risk features found during investigations.
Right. Can you remind us of the main intervention types?
Sure. The definitive treatment is aortic valve replacement, AVR. The traditional way is surgical AVR, SAVR, open heart surgery to put in a new valve. Then there's transcatheter AVR, or TAVI. That's the less invasive one, done via catheter, often through the leg artery. It's a key alternative, especially for older or higher risk patients.
Okay.
Balloon valvuloplasty, just stretching the valve with the balloon, is sometimes used, maybe as a bridge to surgery or in certain situations, but the effect doesn't last very long usually.
Temporary fix.
Kind of. And if someone has had a tissue valve replacement before and it wears out, they might need another intervention, either TAVI and SAVR or redo surgery.
And how are these patients followed up?
Regular follow-up is key, especially for asymptomatic severe AVS clinical reviews and echo scans to watch for changes. For mild AVS, maybe an echo every 3 to 5 years. NICE guidelines provide specific recommendations on who gets SAVR versus TAVI, anticoagulation needs, etc. And of course, any intervention has risks: bleeding, stroke, arrhythmias, infection, things that need to be discussed.
Absolutely, a tailored approach.
Yeah.
So thinking long-term, what's the prognosis like for someone with AVS?
It really depends, Severity is a huge factor. Mild AVS generally has a much better outlook than severe. Progression rate matters, too.
Right.
Age plays a role, obviously. And some data suggests women might sometimes have worse outcomes, possibly due to later diagnosis, though that's complex. The biggest factor, though, is symptoms.
Symptomatic versus asymptomatic.
Exactly. Symptomatic severe AVS, if left untreated, has a pretty poor prognosis. There's a significant risk of sudden cardiac death. Survival rates can be as low as, say, 15–50% at 5 years without intervention.
Wow, that's stark.
It really emphasizes why treatment is needed. For asymptomatic severe AVS, the outcome depends on those risk factors we mentioned: LV function, exercise test results, BNP levels, etc.
And after intervention, after AVR.
Generally, prognosis improves dramatically. Symptoms get better, quality of life improves. For older patients having AVR, their survival often approaches that of the general population their age.
That's great.
For younger patients, while the immediate outlook is much better, their very long-term survival might still be a bit lower than their peers without AVS. There are factors that predict worse long-term outcomes after AVR too, like older age at surgery, other health problems, poor LV function beforehand, arrhythmias, or untreated coronary disease.
So getting the diagnosis and treatment in good time is crucial.
Absolutely. Timely management is key.
Okay. And finally, what are the potential complications if AVS isn't managed properly? What can go wrong?
Well, several serious things. Heart failure is a big one, as the ventricle struggles against the blockage and eventually weakens.
Makes sense.
Arrhythmias, like atrial fibrillation, are more common. The damaged valve is also more prone to getting infected. That's infective endocarditis.
Right, infection risk.
Bits of the calcified valve can break off and travel through the bloodstream, systemic emboli, which could cause a stroke or block arteries elsewhere. And although the absolute risk per year is low, particularly if asymptomatic, there is that increased risk of sudden cardiac death, especially once symptoms develop.
Okay, so a range of potentially serious consequences. Right, well, that was a really thorough run-through of aortic valve stenosis. Just to quickly recap the main points. It's that narrowing of the aortic valve,
Obstructing blood flow.
caused mainly by age-related calcification or congenital issues. Key symptoms to watch for are that triad of breathlessness, chest pain, and dizziness or syncope.
Don't forget the murmur and echo for diagnosis.
Absolutely. And the importance of timely management, whether watchful waiting or intervention like SAVR, TAVI, to improve outcomes.
Definitely. Early diagnosis and the right management strategy really can make a huge difference to prognosis and quality of life.
It really can. And just as a final thought, we talked about the overlap in risk factors between AVS and coronary heart disease, things like aging and calcification. It makes you wonder, doesn't it? Considering that overlap, what other conditions, maybe ones that seem unrelated, might actually share similar underlying mechanisms of, say, chronic inflammation or tissue degeneration? Something to ponder.
Interesting question. And for anyone listening who wants more MSRA revision help, remember to check out pastthemsra.com.
And freemsra.com as well. Thanks so much for joining us for this deep dive today.
Thank you.